Clinician-Directed Performance Improvement, CDPI. And our speaker today was invited by Dr. Achilles, who's one of our pediatricians and one of our CDPI physicians, in the context of a project she's doing more broadly to optimize newborn feeding. And she asked me to just speak briefly here today because this subject is controversial. There are a lot of very passionate advocates for breastfeeding, as they should be, who really feel that our discussing the topic of newborn underfeeding and dehydration could threaten the commitment of the community to really support sustained breastfeeding. So I really want to assure everybody here that our hospital is very committed to supporting sustained breastfeeding. In fact, according to our most recent data from the New Mexico Breastfeeding Task Force that I got from the Quality Department before this conference, is that we rank second in the state for exclusive breastfeeding rates. And first among life-sized facilities. So we have 2 lactation consultants and a speech therapist who see all of our mothers to promote exclusive breastfeedings and support them in achieving that. We recently trained 14 nurses from pediatrics and OB to be certified lactation consultants so that they can support the efforts of our specialists. As I believe that we are the only hospital in New Mexico to have a donor milk program and to have a portable lactation suite, the Mamava, for our associates and visitors to breastfeeding. So I know from knowing our staff, we're very dedicated to supporting breastfeeding, and I hope nobody leaves here thinking that that is not the case. So I'm an ICU doc. I have no expertise in this area at all, except that I had 2 breastfeeding babies. But I did do a literature search before these conferences, and it appears to me that the literature concerning early limited supplementation and long-term effects on sustained breastfeeding is A, of poor quality, and generally, and B, is conflicting. So it doesn't provide us a lot of guidance, and that's unfortunately in a topic where emotions run really high. But I think there are 2 truths that we can all agree on, and the first is that breastfeeding confers important health benefits to babies, and the second is that occasionally a baby in the first days of life, despite best efforts at breastfeeding, gets severely dehydrated and underfed. And those 2 truths, there's room for both of them in the universe. And so I would ask you all to try to approach this topic today openly and academically. Thank you very much for being here.
I'm just going to give a brief introduction. So it's my distinct honor to welcome Dr. Del Castillo to Grand Rounds at CHRISTUS, and indeed back to New Mexico. Dr. Del Castillo attended medical school at UCSF and did her emergency medicine residency at UNM. She studied the effects of hypoglycemia and neonatal brain injury. She's co-founder of the Fetus Best Foundation. It's a nonprofit organization which evaluates scientific literature of breastfeeding complications in relation to hypoglycemia, hyperbilirubinemia, and hypernatremic dehydration. Dr. Del Castillo offers new insight into managing infant feeding practices during what's called delayed lactogenesis 2, or delayed milk production, also known as delayed milk production, and how to safely support an infant during that time. She was recently an invited speaker at the NIH to discuss these issues. We're very lucky to have her here, and I look forward to a respectful discussion at the end of her talk. Thank you, everyone, for coming and for welcoming Dr. Del Castillo.
Thank you so much for this opportunity to talk to you about one of the most important issues in medicine and public health. I'm one of the co-founders of the Fetus Best Foundation, an organization led by health professionals, including neonatologists and pediatricians, committed to the prevention of newborn and infant starvation-related complications and brain injury. I'm here to speak to you about the conditions that lead to the accidental starvation of exclusively breastfed newborns, its consequences, and how to prevent them. I have provided a paid expert opinion on a neonatal hypoglycemia case, the proceeds of which were donated to the Fed is Best Foundation. The foundation is a nonprofit organization and has not and will not accept any donations from infant feeding companies, both breast and formula feeding. The foundation is supported by the private donations and volunteer work of its supporters. All the resources at fedisbest.org is free because we believe that safe infant feeding is a human right. Today I will discuss with you a case of an accidentally starved, exclusively breastfed newborn. I will discuss the basics of feeding, fasting, and starvation, the caloric requirements of newborns and how an exclusively breastfed newborn is underfed. I will discuss the brain and life-threatening complications associated with newborn starvation and the safe limits of exclusive breastfeeding. Lastly, I will discuss how to prevent complications, how to ethically inform mothers of the possibility of complications, and how to promote breastfeeding safely in the hospital and beyond. Landon Johnson was born to a G2P0 mother, full term by emergency C-section, due to fetal intolerance of labor. He was born with good APCAR scores, weighing 3.3 kilos. He developed grunting at 10 minutes and was given oxygen and an IV bolus. His glucose levels were monitored during this time, which were normal, and he was shortly transferred to the mother-baby unit to be exclusively breastfed by his mother. His mother's risk factors for delayed and insufficient milk production were identified by the lactation consultant. And they were borderline diabetes, breast hypoplasia, PCOS, issues with infertility, high BMI, and being a first-time mom undergoing cesarean delivery. Landon was born in a baby-friendly hospital, and mom was supported to exclusively breastfeed with close monitoring by nurses, lactation consultants, and physicians. Landon's first feeding was at 2.5 hours after he was stabilized. During the first feeding, he had difficulty maintaining latch, but it soon improved and was rated at a 10 by the first LC evaluation. The presence of colostrum was confirmed at this time. He fed 12 to 40 minutes nearly every hour the first 12 hours of life. He continued to breastfeed frequently with good latch, and his mother expressed concern about why he was breastfeeding so long and so frequently. She was reassured he was cluster feeding. In the first 24 hours, he had 0 wet diapers and 4 dirty diapers. And at the end of the first day, there was evidence of him tiring out with difficulty latching and fatigue. He breastfed for a total of 9.3 hours the first 24 hours, and he lost 4.76%. From this point forward, he began to breastfeed near continuously with feeding sessions of 45 minutes or greater. And by the second day of life, he was feeding continuously while producing the expected number of wet and dirty diapers. At 53 hours of life, he had lost 9.72% and was discharged continuously feeding with a mother who had no onset of lactogenesis 2, no plan for supplementation, both mom and baby with little to no sleep, and next day follow-up. This is Landon's weight loss before discharge. The last weight was obtained at 7:30 a.m. and the mother had next day follow-up. If her milk does not come in and she continues to exclusively breastfeed, where will Landon's weight loss be in 24 hours at her pediatrician's follow-up visit? Landon continued to cluster feed when they got home. At 2 a.m., 12 hours after discharge, Landon fell asleep while cluster feeding. He was found 30 minutes later, limp, unresponsive, and blue. The father initiated CPR while EMS was called by the mother. What was happening to this baby, and why did he feed longer and longer until he was continuously on the breast? If colostrum provides all the nutrients necessary to meet a newborn's needs, why do exclusively breastfed newborns develop complications, and why would they breastfeed for hours a day with no sleep? Why do most exclusively breastfed newborns cry before lactogenesis 2, and why do they lose weight? And when does a newborn go from hungry to starving, and what are the consequences? All healthy babies are born with all their living cells arranged in a way to optimize bodily function and brain development. This is a picture of a slice of the brain showing the many layers of cells arranged in a way that allows the delicate and complex progression of brain development in order to form a fully functional adult brain. Every living cell needs calories every second of the day to maintain the basic architecture and function of vital organs. Newborns are born with variable reserve. Some are born depleted due to placental insufficiency, prolonged and complicated deliveries, and they're often born to mothers who are fasting. Some are born with high caloric requirements. As a result, the birth weight does not signify the starting point of a full tank from which they can fast. A child who delivers quickly to an unfasted mother may have some caloric reserve, but a child who is born under adverse conditions can be born empty. If a child that does not receive the calories they need to feed all their living cells is fasting and will begin to deplete their glycogen, protein, and fat stores. Once glucose and glycogen are depleted, ketones are converted from fat and become the primary fuel of the fasting newborn. Ketones are known to be present in exclusively breastfed newborns, which reflect their fasting state. If the caloric reserve becomes depleted, then living cells of muscles and vital organs begin to die, and the substrates released are used for fuel, also known as autophagy, or self-eating. This autophagy ultimately results in weight loss. A baby receiving minimal fluid experiences antidiuresis, or slowing of urine output, to maintain blood pressure, which can manifest in 0 to 2 wet diapers a day, the same number seen in 1 and 2 day old exclusively breastfed newborns. However, since lack of urine output results in lethal electrolyte abnormalities, we produce urine even with minimal to no fluid intake. This contributes to accelerated dehydration and eventually hypotension. Hypotensive dehydration leads to lethargy from poor brain perfusion, which eventually causes brain injury, cardiac arrest, and death. Any interruption in fuel delivery from either severe dehydration or hypoglycemia can cause massive brain cell death within minutes of onset. This is a picture of what 10 minutes of interrupted fuel delivery does to the brain in an animal model. The light appearance on the left represents brain cells lost compared to the normal tissue on the right side. Similarly, 20 to 30 minutes of hypoglycemia can also cause massive brain injury that occurs in waves over the next several days, even if normal blood glucose is restored. Hypoglycemia is one marker of critical starvation where the body is running on empty, which causes thousands of brain cells to die upon minutes of onset. Hypoglycemia to the brain is similar to the effects of oxygen deprivation. The longer a baby experiences hypoglycemia, the more brain cells die. Hypoglycemic brain injury results in the loss of the native architecture of the brain required for normal brain development. And unlike many organs, brain cell death has severe and negative consequences. It can result in lifelong disability. This is a brain MRI of a newborn who experienced hypoglycemic brain injury. The light appearance reflects swelling, loss of brain tissue architecture, and cell death affecting half of the brain. In addition to dehydration and hypoglycemia, starved exclusively breastfed newborns develop hyperbilirubinemia, also known as breastfeeding jaundice or starvation jaundice. Bilirubin is removed from the body through bile, excreted by the liver to digest milk. Therefore, bilirubin levels are dependent on the volume of milk a child receives. A fraction of bilirubin can be removed through the kidneys, facilitated by phototherapy, but the most efficient way to reduce bilirubin is through feeding adequate volumes of milk. Without sufficient milk, bilirubin accumulates and can cause brain injury and excess. Exclusively breastfed newborns are known to be at higher risk of developing hyperbilirubinemia because they typically receive much smaller volumes of milk than supplemented and formula-fed newborns. In addition, in the first days of life, it is common to have insufficient milk and have difficulties with effective latch, even with support, which can cause excessive weight loss and starvation jaundice. The primary goal of feeding is to prevent critical starvation that leads to massive body and brain cell death and disability. How many calories do newborns need to not starve and experience brain injury? And why do exclusively breastfed newborns lose weight? The daily caloric requirement of a newborn to keep all their cells alive is a minimum of 100 calories per kilo per day. Their daily fluid requirement is 100 cc's per kilo per day. For an average 3-kilo baby, their daily requirement is 300 calories and 300 cc's of fluid at birth. According to a 2014 study of human milk, the caloric content of colostrum is 54 calories per deciliter, while mature milk contains 66 to 77 calories per deciliter. Unlike what is taught to every mother and health professional, colostrum in fact has fewer calories than mature milk. In addition, colostrum is present in much smaller volumes and is not present at all in some mothers. This is the published average daily colostrum production of healthy, vaginally delivering mothers in the first 4 days of life. These are also the normal accepted volumes of colostrum allotted to newborn babies by the exclusive breastfeeding guidelines. The average mother produces 56 mLs on the first day, then 185, 380 on the third, and then 580 by the fourth day. This roughly correlates to a tenth, a third, and 2/3 of a newborn's caloric requirement for the first 3 days of life, then finally exceeding the full requirement on day 3. This is a graphical representation of the number of calories an average mother can provide a 3-kilo newborn. The blue representing the number of calories colostrum provides, and the red representing the number of calories a newborn requires additionally to be fully fed. Only on the 4th day does an average mother's milk provide the full caloric requirement. Until that time, a newborn is fasting and relying on internal reserves to feed its vital organs. How does the newborn respond to fasting? The newborn loses weight. Weight loss of exclusively breastfed newborns has been widely taught as fluid loss through urination, despite the fact that they only produce 1 to 2 wet diapers their first 2 days of life. So why do exclusively breastfed newborns lose weight? The same reason why we all lose weight. Exclusively breastfed newborns are losing weight because the caloric and fluid content of colostrum does not meet the full metabolic demand. They are losing weight because they are fasting. The only thing that rescues them from this fasting state is the onset of copious milk production of the mother. How often do exclusively breastfed newborns have to fast longer? This is a study of 280 mothers who were motivated and lactation supported. 22% of the mothers had delayed onset of lactogenesis, which increased their child's risk of excessive weight loss by 7-fold. The leading risk factor for delayed lactogenesis too was being a first-time mother, which occurred to 34% in the study. This is another study showing that 44% of first-time mothers have delayed lactogenesis too. As a result of these fasting conditions, the most common complications of exclusive breastfeeding before lactogenesis are hypoglycemia, excessive weight loss, dehydration, hypernatremia, and hyperbilirubinemia, which together make up the syndrome of starvation. Starvation is defined by caloric and fluid deprivation that results in injury to the brain and vital organs, which, if uncorrected, lead to death. The leading causes of newborn hospitalizations are complications associated with insufficient feeding from early exclusive breastfeeding. This is data from a large Utah healthcare system documenting that the most common reasons for newborn readmissions were for feeding problems and jaundice. The American Hospital Association's data shows that jaundice is the leading cause of newborn readmissions and is increasing in incidence. Among all the readmissions, 78% of newborns receive phototherapy. The literature estimates that 86% of jaundice admissions results from non-hemolytic or starvation-related jaundice. Among healthy term exclusively breastfed newborns, 10% of vaginally delivered and 25% of cesarean-delivered newborns develop excessive weight loss of greater than 10%. Excessive weight loss increases the risk of hyperbilirubinemia, hypoglycemia, and hypernatremia. Exclusive breastfeeding has been shown in multiple studies to increase the risk of rehospitalization for complications related to insufficient feeding. It has been shown to increase the risk of readmission for dehydration and jaundice by 2 to 11-fold. It has been shown to independently increase the risk of hypoglycemia admission by more than 2-fold. And lastly, hypernatremic dehydration is near universally a complication of attempted early exclusive breastfeeding. The Academy of Breastfeeding Medicine estimates that 10 to 18% of exclusively breastfed newborns develop starvation jaundice. One baby-friendly hospital system published that 5.7 to 10% of their newborns required phototherapy. This correlates to an estimated 228,000 phototherapy admissions annually in the U.S., costing approximately $3.3 billion, the majority in underfed breastfed newborns. The cost of lifetime care for a brain-injured child who sustains breastfeeding complications are millions more per child. Why do complications occur if exclusively breastfed newborns if colostrum is enough and 10% weight loss is normal? Why do we think that 10% is normal? This idea comes from a 1984 study of 7 vaginally delivered exclusively breastfed newborns. 2 babies lost 10% and 1 failed to thrive. This study did not report on negative consequences of weight loss and failed to report on basic markers of starvation like glucose, sodium, and bilirubin. In addition, they failed to study long-term negative consequences of weight loss of the newborn brain. 2 babies lost 10%, and that established the standard of accepted weight loss for billions of families. How can this be if we survive through exclusive breastfeeding? If you look at the published data on native practices of breastfeeding mothers all over the world, there is no historical evidence that we have ever widely exclusively breastfed from birth from a single mother. Before the WHO guidelines, newborns were near universally supplemented in the first days of life with prelacteal feeding, most commonly with the milk of wet nurses, animal milk, or sugar water. This is a sampling of countries showing the prevalence of prelacteal feeding prior to the WHO guidelines, showing that 88 to 100% of newborns receive some form of supplementation in the first days of life. Yet despite the high incidence of prelacteal feeding, the vast majority of babies were breastfed to 1 to 2 years of age without ever experiencing the fasting conditions imposed by early exclusive breastfeeding. Why was prelacteal feeding common? The most common answer given by breastfeeding mothers is that their milk is not enough. Simply put, mothers use prelacteal feeds because they used their common sense and did not want their babies to starve while waiting for their milk to come in. In fact, a study of Nigerian nurses and doctors found that nurses gave these feeds for milk insufficiency, while doctors gave them to prevent dehydration, hypoglycemia, and jaundice. Now these complications are the most common causes of newborn hospitalization in the world. The stance of the WHO and the Baby-Friendly Hospital Initiative is that nothing but breast milk is appropriate from birth to 6 months, without any quantitative data on the breast milk production of mothers during that time period, and despite widespread perceived inadequacy of colostrum by breastfeeding mothers. They stated that colostrum meets the nutritional needs of newborns without ever making any reference to the caloric content of colostrum or the caloric requirements of newborns. Whose perception of milk adequacy is correct? Mothers and health professionals are taught that the newborn stomach is tiny. However, where does this teaching come from? This is a widely distributed picture of the size of the newborn stomach. However, this is an estimation from a 1988 study on the average daily colostrum production of 12 healthy, exclusively breastfeeding mothers divided by 10. They did not actually measure the newborn stomach. They incorrectly assumed that the colostrum production of a mother should perfectly reflect the size of the newborn stomach. What is the actual size? This article, summarizing the findings of 6 articles, found that the actual size is 20 cc's at birth. In addition, the stomach empties into the intestines during feeding, and newborn babies have been known to easily take 30 cc's or more per feeding on the first day of life, depending on the caloric reserve and metabolic demand. How often and how soon do healthy, exclusively breastfed newborns develop hypoglycemia given their fasting state? The first study of hypoglycemia in healthy-term, exclusively breastfed newborns was published in 2015, where they looked at newborns undergoing the baby-friendly protocol. The mother-baby dyad strictly followed the protocol, and the babies had good sucking reflexes and latch. They checked their glucoses at 1, 6, 24, and 48 hours, and found that 10% of all the newborns developed hypoglycemia of less than 40. They found that firstborn babies were at even higher risk, with 23% developing hypoglycemia within that time frame. At this time, it is unknown the incidence of hypoglycemia on the 3rd day of life, given that the majority of babies will still be fasting on the 3rd day. What does hypoglycemia do to the brain? In a study of 94 newborns who had brain MRIs, they found that newborns who had hypoglycemia of less than 46 were 3.7-fold more likely to have brain injury on MRI and 4.8 more likely to have lower scores in motor, cognitive, and language development at 12 months. The effect of hypoglycemia persists, as shown by the study of almost 1,400 newborns universally screened for hypoglycemia by 3 hours of life. They looked at the effects of transient hypoglycemia on a child's ability to pass 4th grade proficiency tests in literacy and math. They tested 3 different cutoffs. For newborns with hypoglycemia of less than 45, they had 38% lower rates of passing the literacy test. And for those who had glucoses less than 35 and 40, they were around 50% less likely to pass the test in both literacy and math. Hypoglycemia was found to be common and occurred in all newborns, including healthy-term, appropriately sized newborns, which means all newborns are susceptible to hypoglycemia and associated brain injury, because being born depleted of calories is common. Despite correction, hypoglycemia negatively affected the newborn's long-term academic potential in all 6 categories, only 1 not reaching statistical significance. Therefore, what we call the physiologic nadir of glucose found in newborns shortly after birth is common but not benign. And brain cells do not care what time you were born when deciding to live or die from hypoglycemia. Newborn lethargy occurs when the brain is no longer supplied with enough calories to keep the brain awake. The most recent article on lethargic newborns who develop hypoglycemia from insufficient breast milk intake suggests that by the time they are found lethargic, they may already have devastating levels of brain injury visible on MRI. This article described 11 previously healthy-term, exclusively breastfed babies who were found lethargic from hypoglycemia. The complications occurred between the 2nd and 5th days of life. They lost anywhere from 0 to 16% of their birth weight, and the majority losing less than 10%. They are found lethargic, poorly feeding, seizing, hypothermic, and apneic. 5 out of the 6 brain MRIs obtained found extensive areas of injury affecting several lobes of the brain. Here are those 11 babies. This presentation will be available on fetusbest.org, by the way. The babies went on to have long-term neurological disabilities, including epilepsy, diffuse body weakness, visual impairment, and feeding difficulties requiring speech therapy. This is an example of a brain MRI of starvation-related hypoglycemia in a breastfed newborn 1 month after the event, showing injury to the parieto-occipital lobes. In a larger study of newborns with isolated symptomatic hypoglycemia of less than 47 who received brain MRIs, they found that 33 out of 35 had visible brain injury affecting every area of the brain with every possible distribution. The brain MRI showed everything from small areas of injury to extensive cortical and white matter injuries. Because the injury from hypoglycemia occurs in varying patterns, hypoglycemic newborns develop differing patterns of disability, which included frank cerebral palsy and other deficits in motor, sensory, language, and cognitive development, as well as seizure disorders. What these studies tell us is what the basic science of hypoglycemic brain injury tells us. Hypoglycemia causes brain injury easily and rapidly, and can reduce a child's cognitive potential irreversibly. That just one episode of starvation can disable a child for life, and the best way to protect the newborn brain is to prevent the hypoglycemia from happening in the first place with adequate feeding. The latest studies suggest that exclusively breastfed newborns should be monitored for glucose, similar to other high-risk babies. Glucose monitoring is the only objective measure of a baby's fuel reserve. Without that monitoring, only the baby knows how close they are to empty. When does evidence of brain injury begin to occur according to the scientific literature? By glucose of 47. The brain mounts the neuroendocrine response to counteract hypoglycemia by 50 to 60 in order to protect itself from injury, which is the reason why the Pediatric Endocrine Society recommends keeping glucose levels above 50 to 60. There is no benefit to hypoglycemia, and steering us far away from the hypoglycemic threshold by ensuring adequate feeding is one of the most important ways we can protect the newborn brain. The epidemiological data on hyperbilirubinemia typically defines the condition as greater than 15. And developing the diagnosis of hyperbilirubinemia has been associated with multiple developmental disabilities, including ADHD, epilepsy, seizures, and delays in motor, sensory, auditory, visual, language, and cognitive development, also known as bilirubin-induced neurological disorder. Blood markers of brain injury have been found to be elevated by bilirubin levels as low as 17 and accelerates at 19. At levels above 19.9, one 30-year follow-up study showed that 45% of jaundiced newborns develop neurobehavioral problems, including ADHD, poor academic achievement, and higher rates of alcoholism. These bilirubin levels are common. One baby-friendly hospital system reported that 12 to 20% of babies born in their system develop bilirubin levels above 15. When does hyponatremia and dehydration cause brain injury? It occurs at a sodium of 150. In a study of 116 cases of breastfeeding-related hypernatremia, over 50% of the babies exhibited abnormal development by 12 months. And in another study of hypernatremia, 95% of the cases occurred by 7% weight loss. At this time, over half of all healthy-term, exclusively breastfed newborns lose greater than 7%, which means half are at risk for brain-threatening hypernatremia. According to a second study, hypernatremia can be present at less than 5% weight loss. Hypernatremia is considered to be rare. This data suggests that it is in fact not rare. It is only considered to be rare because it is not routinely screened for. Hypernatremia causes injury to the brain and vital organs and can result in epilepsy, long-term disability, and death. Mortality increases with increasing severity of hypernatremia. The current maximum recommended weight loss according to the 2012 AAP breastfeeding guidelines is 7%. Greater than 7% weight loss increases the risk of developing hypernatremia and hyperbilirubinemia. There is no study using standardized developmental testing proving the safety of 10% weight loss. Only one study on the neurological outcomes of newborns experiencing weight loss exists, showing that newborns who lost greater than 12% had reduced fine motor skills, higher rates of parental concern for language delay, and higher rates of parental reports of shyness, allergies, and disability. This is what mothers experiencing in real life. This is one of thousands of stories we have received. My child went through this trauma. He was born healthy and was fed continuously the first 2 days. He was irritable, was always rooting in spite of being fed continuously. 24 hours later, he became unresponsive and was taken to the NICU, where they stated that his blood sugar dropped to 0. The baby didn't get any milk from me at all. The hospital staff didn't even care to check if I was producing any milk. They blindly suggested to feed the baby continuously and didn't recommend formula. He had brain injury because of this. 1/3 of his brain got affected due to severe dehydration and hypoglycemia. The hunger and thirst experienced by fasting exclusively breastfed newborns is most evident by the second day of life, and is so common that it has earned the name the second night syndrome. This is what an underfed, exclusively breastfed newborn experiences in the hospital.
From the beginning, but then after a while, it wouldn't latch on. It was very stressful. So as far as getting on and sucking, what do you think? She's learning that part.
She wakes up again and not let you call us because we need to make sure she's, yellow sugar.
They tell us that, she's jaundiced, and the key to getting that out of her system was to keep feeding her so that she could poop it out. But I couldn't get my milk to come in fast enough.
She's okay for right now, but they'll check her again. We have to watch them closely.
When you're trying to breastfeed and it's not working, it's very stressful, and I think that the baby can sense that stress.
Thank you, Nancy. Appreciate it.
I already feel like a bad mom. It makes you feel like a failure.
Listen, there's a lot of moms that the baby doesn't latch on and they give up. I mean, I commend you. I mean, you're awesome because you didn't give up. I know you will. So tired. Okay. It's okay. I forgot how hard babies are.
Into my life while you were out shopping. 4 o'clock in the morning, after the nurse had taken Sophia to the nursery, she came back in and said that Sophia's blood sugar was low.
I mean, I hope and pray that they do, but they're like, hey, their baby's never going to leave here until the glycemic level's above 55.
I have to admit, I was pretty scared this morning for the first time about her health.
We're having to use donor milk because I don't think her breast milk came in.
It takes 2 or 3 days for the first time, Mom.
I know, but you know how doctors are these days. They're giving us a lot of static. I love it. They were kind of hammering Mars early this morning to give the baby bottle formula because the baby wasn't getting enough sugar in her bloodstream because Mars's milk hasn't come in. I said, absolutely not. Hell no.
We wanted her to have breast milk.
Okay.
And we wanted her to try to latch normally and not use a regular bottle. Because we didn't want her to get confused between natural breast and the bottle nipple.
So we compromised with the nurses and administer donor breast milk with a syringe. Yeah, there you go. But that's not easy.
So I plan to supplement with that as much as I need to, but also just try to make sure she's nursing regularly as well.
Almost there. Keep sucking. No, it's okay. The baby's got to keep drinking more breast milk continuously, or we're at risk of staying here another night.
I just hope that Sophie is healthy, and I just really hope that we can make everything right.
God, don't start that we can't take the baby side?
No.
This is just called, legal hospital paranoia. Everyone's freaking out because her glucose level was at 37, so they're like, oh boy. There's an alarmist mentality, I believe, in the hospital industry. It's about liability.
Hello, how are you doing? Frustrated?
Yeah.
Okay.
Why are you gonna keep our baby?
Well, we have to keep the baby because she's symptomatic from having a low blood sugar.
My
So,
mom's a lactation consultant, and she said that's very common, especially when she's trying to produce milk.
yeah, it is common, but we've got to make sure the baby's safe.
For liability reasons.
No, for her brain growth.
For her brain.
Growth.
So you'll be able to monitor her brain to know before you discharge her whether or not
The blood sugar, we can monitor. She could go into a coma if she doesn't have the high enough blood sugar.
How
We
often
wouldn't
does
want
that
to
happen?
Well, we prevent it a lot, that's why it doesn't happen.
It's actually common to go up and down from everything over there.
It is, but it's not safe for a baby to have it under 40. That's why we want to constantly keep track of it.
Sorry, Mars.
I don't want to leave her.
Well, I think that we need to get some type.
Okay, I'll stop there. Baby also went on to need further therapy for hypoglycemia. Going back to our case, Landon was limp, pulseless, and cyanotic, and the CPR was initiated by his father and was continued by EMS en route to the ER. He required 2 IOs and was intubated in the ER. He was found to be hypothermic with a rectal temp of 93 and in PEA arrest. He got several rounds of epinephrine with no return of circulation, and after 45 minutes of CPR, no cardiac activity was found on ultrasound. CPR was then stopped after discussion with his parents while mechanical ventilation and IV fluids were continued. After 20 minutes of IV saline infusion without CPR, he regained his pulse. He was transferred to the nearest level 2 NICU, and there he was diagnosed with hypernatremic dehydration from poor feeding and cardiac arrest from hypovolemic shock. Landon's MRI showed injury to the basal ganglia, and the EEG showed diffuse slowing and seizures consistent with widespread brain injury. Given his poor prognosis, he was taken off life support and died at 19 days of age. This is him a few hours after birth and 12 hours old. By the second day, he was hungry, constantly crying and nursing. And this is him before discharge, visibly smaller and cluster feeding. This is Landon intubated after resuscitation. This is Jill holding Landon, as he took his last breath. According to the baby-friendly guidelines, mothers are not counseled on the risk factors for insufficient milk production and breastfeeding complications. Even risk factors identified, their babies are not offered immediate supplementation, even if showing signs of poor feeding, despite lack of data on the safety. Parents and health providers are taught that even drops of colostrum is enough, and that newborns can safely go days with minimal intake when there's absolutely no scientific evidence supporting it. Exclusively breastfed newborns are not monitored for hypoglycemia despite their fasting state. Prolonged crying and nursing, which can be signs of hypoglycemia, are commonly not signs or do not commonly initiate glucose checks or supplementation. The baby-friendly protocol operates with no awareness of the caloric requirements of newborns to prevent starvation and brain injury, and no awareness of the caloric yield of a mother's colostrum. It believes that 5 cc's of colostrum, which provides 3 calories to a newborn that burns an average of 12 calories an hour, can prevent hypoglycemia when it cannot. And it operates with no knowledge of the calories transferred to a child until starvation-related complications occur. Mothers are told that insufficient breast milk is rare, when it is in fact common, especially in the first days of life. and that supplementation can protect an infant's life and brain. They are taught there are no risks to exclusive breastfeeding from birth, and there are risks to just one bottle of formula. Mothers are not told about the possibility of completely preventable starvation and brain injury until their babies are affected. Sadly, supplementation is often given once brain-threatening complications have already occurred, after which a baby often requires hospitalization that mothers are not told their child is at risk for. Mothers are pressured to withhold supplementation when their babies are crying for milk. If they insist on formula supplementation, they are often shamed and required to sign a form suggesting that they are negatively affecting their baby's health. Mothers are sent home by 48 hours before they have adequate milk to safely sustain their baby's life and are told to not supplement with formula regardless of their milk production. They are told that crying and nonstop feeding, signs of newborn starvation, are normal when they can be signs of critical illness. As a result, starved, exclusively breastfed newborns are commonly found too weak to feed or lethargic from jaundice, hypoglycemia, and dehydration in the hospital and shortly after discharge. And for babies, and according to the most recent article on lethargic breastfed newborns, the article suggests that by the time they're found lethargic, debilitating levels of brain injury that lead to lifelong disability may have already occurred and cannot be reversed. And according to our meeting with top officials of the WHO breastfeeding guidelines, Dr. Nigel Rollins and Dr. Lawrence Grumer-Strawn, the baby-friendly, newborn exclusive breastfeeding guidelines have never been tested or monitored for safety. When asked about the WHO's plan to inform the public of the risk of brain injury from insufficient exclusive breastfeeding, Dr. Rollins said it was not identified as a top priority. He stated that health professionals trained in the baby-friendly protocol are taught to look for danger signs, including lethargy, convulsions, and poor feeding, all late signs of newborn brain injury. Feeding and being fed are basic patient and human rights. A mother cannot be barred from feeding her inconsolable and hungry child. And a newborn baby has the right to be fed when they are crying for milk and experiencing the torture of hunger. And like what many mothers are taught, an inconsolable crying newborn who is losing weight from fasting is crying out of hunger. Feeding is more important than exclusivity in breastfeeding because the brain will not wait for food. Any distressed newborn requires immediate evaluation of glucose, bilirubin, electrolyte, and weight check, and likely supplementation while in the hospital. If a full evaluation is not immediately available, supplementation should be offered to prevent the irreversible consequences of starvation-related brain injury. Only when the baby is no longer in distress can the breastfeeding be evaluated. You cannot ethically gain compliance with exclusive breastfeeding before lactogenesis without truthfully informing mothers that their newborns are fasting and are at higher risk for rehospitalization, irreversible brain injury, and death from accidental starvation. Complications caused by lack of informed consent is the liability of the hospital and health professionals who fail to provide that information. And what is the cost of that liability? In a study of 30 claims for neonatal hypoglycemic brain injury, 25 of 30 claims were awarded an average of £6.5 million or $10.3 million. More recently, in Arkansas, a breastfed newborn with blood type incompatibility was sent home with a mother not informed of the high risk of jaundice and its consequences. The baby exhibited high-pitched crying while at home. Her provider failed to return her phone calls, and by the time they were seen, the bilirubin was 33. She had confirmed kernicterus on MRI. The child is wheelchair-bound, cannot talk, feed, or care for herself. The family was awarded $46.5 million. In response to the thousands of mothers who've written to us about their breastfeeding tragedies, the Fed is Best Foundation has developed guidelines for safe early breastfeeding. The guidelines call upon the joint collaboration of mothers and health professionals to closely monitor and ensure adequate feeding. Clinical data and recommended thresholds for supplementation are shared with mothers so they may be equally informed of critical data, protects her child from her child's brain and future potential. It is vital that they are informed, as tragedies in infant feeding have severe and irreversible consequences. The goals for no child to experience brain and life-threatening complications from underfeeding, and that no child is disabled by starvation. Feeding education begins before birth, and mothers who want to breastfeed can learn how to breastfeed through free sources like the Stanford Medicine website. Mothers can download and fill out their desired feeding plan, which is available for free on fedisbest.org. The feeding plan has a checklist of risk factors for delayed lactogenesis and feeding complications, and outlines options for supplementation if exclusive breastfeeding is insufficient to safely feed a newborn. They can review that feeding plan with their in-hospital pediatrician and staff before birth. At this time, mothers should receive informed consent regarding the fasting state of exclusive breastfeeding before lactogenesis 2 and the risks of brain injury from jaundice, dehydration, and hypoglycemia from insufficient feeding. In addition, they can be counseled on the risks of decreased milk supply if supplementing without adequate time breastfeeding. Before every breastfeeding session, mothers can manually express their breasts. Breastfeeding should occur within the first hour to prevent hypoglycemia, and at this time they can be taught a proper technique. Breastfeeding should occur 15 to 20 minutes each breast every 2 to 3 hours while manually expressing. Longer feedings can cause babies to burn more calories than they take in, which can accelerate weight loss and increase the risk of hypoglycemia. If little to no colostrum is present, a mother may choose to supplement to prevent starvation-related complications. This can be done with 15 cc's at a time, repeated until satisfied with safe tested donor milk or formula. Allowing newborns to determine how much milk they receive allows them to correct starvation-related abnormalities, which help them protect their brain and vital organs. Finally, supplementation only after breastfeeding will preserve the stimulus for breast milk production while providing needed calories. Exclusively breastfed newborns are high risk for hypoglycemia due to fasting. Babies should enter the glucose monitoring protocol per the hospital protocol. Babies found hypoglycemic can enter the hypoglycemic protocol. The neuroendocrine response occurs at 50 to 60 to protect itself from its own survival. The brain's preference should be honored. Keeping glucose over 47 is the only prospectively validated glucose level that prevents developmental delay. If glucose is less than 50, the baby is likely depleted of calories. We recommend ad-lib supplemented breastfeeding until breastfeeding provides the full caloric requirement of the newborn. We need to restore caloric reserve to stabilize glucose because recurrent hypoglycemia can cause worsened brain injury. This is what blank staring looks like from hypoglycemia. The signs of newborn hypoglycemia can include no symptoms, but the following signs are reasons for immediate glucose checks and at least correction with oral supplementation if none is available. This newborn lost 9.8%, became limp and blue at home. The glucose was 22. Please note that a hypothermic, hypoglycemic newborn may be minutes away from cardiac arrest. Do not recommend skin to skin, check a glucose, and deliver calories to the brain. Wet and dirty diapers do not predict adequate milk intake in the first 4 days because most of those diapers come from what they're born with. Even dehydrated babies can produce 6 to even 8 wet diapers on day 4. Dehydrated babies can also produce dirty diapers as well. Obtain weight checks every 12 hours because the fastest losing baby loses 7 to 8% in 24 hours. And according to AAP, they should not lose greater than 7% because of the risks. The newborn weight loss tool can be used to graph that weight loss and can justify earlier supplementation, but it does not tell you whether a child is safe from breast-threatening complications because a child can become hypoglycemic hypoglycemic at any weight loss. Provide a minimum of daily bilirubin checks until onset of copious milk production and daily weight gain, both in the hospital and at follow-up. Bilirubin levels are the most important labs we check in healthcare. It is unacceptable to allow newborns to develop bilirubins that put their future at risk when almost all excessive jaundice can be prevented with adequate feeding. In addition, advising mothers to use sunlight or phototherapy alone to reduce jaundice without ensuring the full delivery of milk of 6 ounces per kilo per day is ineffective and dangerous. Newborn distress should signal evaluation and lab work. And it should also be done close to the time of discharge. The reasons for supplementation are the following and include the most important people in the relationship, the mother and the baby. A baby is the only one that knows how close they are to empty. Supplemented breastfeeding is a valid and safe feeding choice, as no benefit of exclusive breastfeeding justifies the risk of starvation-related brain injury. Supplemented breastfeeding before lactogenesis 2 was the norm before the BFHI to prevent starvation and complications. Pediatrics trained physicians and nurse practitioners are the only health professionals qualified to fully evaluate a newborn with labs for starvation in order to determine the safety of withholding supplementation. But the ultimate authority over the decision to supplement is the mother. It is her human right to protect her child from hunger and injury. Exclusively breastfed newborns being sent home before lactogenesis 2 are fasting. We need to provide mothers education on the signs and symptoms of newborn starvation and provide them the calculated 7% weight loss threshold. We can provide instruction on how to supplement while protecting the supply in the event her milk does not come in to prevent newborn brain injury. And finally, next day follow-up should be offered and include bilirubin, electrolyte, and glucose checks, as well as discussion of safe weight loss limits. We recommend supplementation for distressed newborns at home because of this. This is kernicterus, and this child is already experiencing brain injury and will be disabled. 90% of kernicterus occurs in breastfed babies, particularly those who lose greater than 10%. The majority of these babies are showing signs of distress before they are disabled. This is an example of how we teach mothers how to look for the signs of newborn distress. Mothers should have a home baby scale. Before lactogenesis 2, they should weigh their baby every 12 hours at home to prevent that 7% weight loss. And then it can be checked again and again in order to prevent failure to thrive. This baby lot only gained half an ounce from their birth weight 1 month into their breastfeeding relationship, despite hours of nursing a day. Supplementing while protecting the breastfeeding relationship is easy, safe, and humane, and has protected the brain and lives of millions of babies for millennia. And this is found on vetisbest.org. While the data is limited, there is no prospective data supporting that properly managed supplementation interferes with breastfeeding. But the limited data there is, it shows either no effect on breastfeeding, long-term exclusive breastfeeding, and in one small study, even improved breastfeeding. This latest study showed that the same findings, and all 4 of the readmitted babies were unsupplemented. And in addition, there were no changes to the gut microbiome. I'm just going to skip over this so you can read that at your leisure. In summary, a newborn who is persistently crying or nursing or lethargic is hungry and is in danger of serious complications if not adequately fed. Exclusively breastfed newborns need closer monitoring of glucose, bilirubin, electrolyte, and weights. Newborns can be supplemented to prevent complications without compromising long-term breastfeeding success. No benefit of exclusive breastfeeding justifies the risk of starvation-related brain injury. We cannot continue to ignore the harms that aggressive exclusive breastfeeding promotion causes. If we fail to safely feed an infant in the pursuit of exclusive breastfeeding, we can permanently take away their future potential. We can take away their ability to pass 4th grade math, their ability to go to college, their ability to hear, to see, to speak, to think, to walk, or to live an independent life. Starvation-related brain injury is a mistake that can never be reversed. The only way to protect all newborns is to give all mothers the whole truth, the real risks and benefits of their feeding choices, and how to recognize and prevent unacceptable and irreversible outcomes. As parents and health professionals, we have a responsibility to protect every newborn from starvation, to help ensure that they thrive, grow, and reach their full potential. We achieve this by supporting every mother to protect her child with safe and sufficient feeding. I leave you with a quote from Fed is Best supporter Dr. Vinod Bhutani, the lead author of the 8P Newborn Jaundice Guidelines. This slideshow will be available on fedisbest.org, and there are cards all over the place, but please feel free to take a stack of cards if you wish to give them to parents or patients, friends, whoever you want. Thank you. Are there any questions or thoughts?